The labrum, just to understand it, is a little like a gasket or a rubber washer, and that washer sits between the ball and socket of the shoulder joint. And as you look at this picture over here, you can see that gasket or ball and socket, and then when you look at it on face, we can again see it is a very distinct structure. Anatomically, we break it up into an inferior and posterior and a superior and anterior quadrant. And really think about this like a clock face. And really depending upon the sport and the type and the nature of the injury, we can really define where on the labrum that injury happens. It's a nice analogy to think about the shoulder, a little like a golf ball that sits on a golf tee. That structure is not inherently stable. So by adding this rubber suction cup or this labrum to the shoulder becomes somewhat more stable. And if we simplify it to the chalk blocks that one might put behind their car when it's on a hill, those chalk blocks, like the labrum, can help hold the ball or the ball and socket in place. The most common injury that we see in throwing shoulders and throwing labrums is the superior labral injury. We have an acronym or a mnemonic called a SLAP, and it's always confused me, but it refers to the superior labrum and the relative position of the injury on the superior labrum to the biceps, and it comes in front of and in back of. And on the bottom here I can see a shoulder, a labrum, a biceps. This is in a baseball thrower, and an injury to the labrum on the superior aspect of it. Historically, many problems we talk about were discovered in the 15 and 16 and 1700s, but superior labral tears were not discussed until 1985, and treatment of superior labrums did not really start to occur significantly until the 1990s. Perhaps, as Bob had suggested, this is when the rage in baseball and the hyper-participation occurred, and the importance of participating at a high level at a young age. If we think about why labral tears occur, and this will sort of follow with my elbow talk, throwing, or the art of throwing, is a very, very challenging job for a body. And it goes through several specific phases. Each of these phases, as we look at them through time, have the body and the arm in different places and positions. As we get into this cocking phase, or this late cocking phase, that we can see up here in this national picture, the arm and the tendons in the arm are under a significant stress. So perhaps one of the etiologies, and here we're looking at an axial view, so looking down on top of the shoulder as the player has their arm rotated out into this position, what the normal biceps and superior labrum look like, and as it gets torqued and pulled all the way back into this position. And you can imagine, through repetitive cycles, thousands and thousands of times in the absence of appropriate pitch counts, how that could peel back that labrum and in a relatively slow and atraumatic way tear and injure that labrum. The diagnosis can often be somewhat challenging because these are injuries that are associated with the entire shoulder, the other aspects of the labrum, instability, the other joints around the shoulder, the AC joint, the biceps tendon. And there's at least 8 different descriptions on how we can diagnose this, and no single description, or for that matter, no combination of descriptions for diagnosing this problem have really been very, very effective. One of the tests that I like to use is the Kim test, described by a South Korean doctor, where I can bring the patient's arm into a position of flexion, have the patient flex their arm, and then supinate and pronate, and I can often tell a differentiation. And what's happening here, at least clinically, is the biceps, or the angle at which the biceps is being loaded, is somewhat different. There's many other named tests for this. Dr. Sullivan gave us a nice lecture on radiography. Well, x-rays and MRIs are wonderful, and in this situation, in fact, in 99% of the world, the diagnosis is aided with an MRI arthrogram, where we put dye into the shoulder. But nonetheless, this is still a very imperfect test. And there are times when we're going to have to operate on someone in the absence of MRI findings, or we just can't find out what's wrong with the current standard testing. Orthopedic surgeons really like to classify and put each type of injury into a subcategory. I think the reason to even discuss these is just so you can see some of the pictures. Here's a mild tear of the labrum. Here's another more significant tear of the labrum. Here you can actually see part of the labrum detached, almost like what we call a bucket handle, flipping into the joint, a lot like that cartoon shows. And here you can see one after a dislocation and a trauma. So the visual appearance of these at the time of surgery is relatively straightforward. Anyone who's come to my talks before knows that I like to show the gory pictures of surgery. And here we are looking inside someone's shoulder. This is a normal rotator cuff. This is a college level picture. And what I'm doing is I'm creating what we call portals. This is the biceps tendon. This is a cannula. And over here is the humeral head. And as I put these portals in, these microscopic or arthroscopic access ways, I'm able to address and surgically repair and diagnose the different conditions in the shoulder and hopefully get this individual back. As I speed this up a little, what you can see here is using the different instruments, I'll use mechanical shavers and abraders and different tools to create and prepare a healthy surface for healing. Here I'm drilling a hole into the bone, and once I've drilled this hole, I'm going to insert a device like a concrete anchor, and this concrete anchor is going to have stitches attached to it. We call them suture anchors. Right here you can see it, and that's how I can stitch something to bone. This is how I'll be able to stitch the labrum to bone. Now I've got the stitch in the bone, and the next trick is after here I'm showing you I've determined where the tear is. I'm going to show you how I actually take an instrument and make a ship inside of a bottle or repair it. This has really been, and here with this small sharp device, and this is real time, this is just the way I see it as you're seeing it right here. I'm watching this on a camera, and perhaps it was good that I played video games as a child and didn't work out to be a pro athlete. Although I had the height apparently. Here you can see, slowly and methodically, pushing my way through, and then I'll use this device to shuttle or to transfer the stitch that comes out of the bone into this labrum. And I'll repeat this step as many times as it takes. And you can see, really, it's a very slow, methodical, careful motion that I'm doing. This is exactly what happens in the OR. It's not any sort of total joint replacement hitting with a hammer or anything like that. That was a dig at some of the joint replacement surgeons, in case. And this, there's a sophisticated medical device I'm going to reach in here with in a second. It's called a crochet hook. And I'll use that crochet hook, and I'll pull the stitches out. And what happens afterwards is that I tie a Boy Scout knot. Here I am passing the second. And then I'll pass this through and I'll tie my Boy Scout knots. And these knots get tied inside the body, and this is sort of a type of thing where you just take time, you learn how to do it. You'll see a little device come down. It's, again, a sophisticated medical device. This time we call it a knot pusher. And that knot pusher slides that down, and this repairs that labrum back down to the bone. And I think it's interesting to see because we talk about these, and with professional baseball players, we see this on a regular occurrence. Sometimes, instead of just having pain from throwing, the shoulder actually dislocates. And this is an x-ray of a dislocated shoulder. You can perhaps see that the ball is not inside the socket. And when the ball comes out of the socket, there is an injury to the labrum. So here again, thinking about the golf ball and the golf tee or the chalk blocks, what's happened is the ball has jumped over the chalk block. When that happens, the tissue tears. We get an MRI scan. An MRI scan will show me a nice chalk block in the front, but this chalk block is absent. It looks blunted. The MRI scan can also show me other areas of the bone that may have been injured when it comes out of the joint. Sometimes I have to get x-rays additionally or CAT scans because not only does the chalk block get injured, but the bone can fragment. When I examine a person after they've had instability, especially after they've had it numerous times, you can actually have them dislocate their shoulder in the office. It gets worse. If this was too much, please do close your eyes. This young guy's had 17 dislocations and just thought it was kind of cool and okay. And as you push on his shoulder, awake and alert, his shoulder will pop in and out of joint. And he doesn't even flinch. As orthopedists, we're into the gore of it, so we're going to watch it more and more and more. While Bob Bigelow may take questions afterwards, I'll show videos afterwards. So who do I fix? Why do I fix these things? For a non-athlete, and I don't mean someone who just doesn't like to play sports, but for someone who's not involved in an organized competitive sport, we're talking about high school, college, and professional athletes. Non-operative surgery, non-operative treatment for a first-time dislocator is very reasonable. For athletes, however, the chances of them redislocating when they're 17 to 18 years old is somewhere between 80 and 90%. So we're going to look at what sport they play. We're going to look at when in the season. If this is a football player who's in their senior year who dislocates in the beginning of the season, we're going to try and rehabilitate them in a safe and reasonable way and allow them to complete their season and then repair them at the end of the season. We'll look at their anticipated demands. Getting even more complicated, there are kids who are just generalized ligamentously lax. Contact athletes we may be more likely to fix in a more active way. Continue with good videos. I'll bring these individuals to the operating room and then under anesthesia. So some patients let you dislocate their shoulder awake. Other patients, on the other hand, have to go to sleep. So what you're seeing here is the shoulder sliding in and out of socket right there while the patient's asleep. So with no neuromuscular control, without the things that Alicia is able to fix, there's really no holding this thunk shoulder in place. And here's what happens when I fix the instability of the shoulder. The first thing I'm looking at here is the ball and socket. The patient's laying on his side. So this is the socket, and this is the labrum that I can see in the front of the shoulder. And it's healed down into the wrong position. And in the wrong position, it doesn't work as a chalk block. It's almost like a flat piece of tissue. And we mobilize this tissue. And you know, one of the questions someone says, it doesn't bleed a lot. What's going on? Well, I will try and make it bleed a little bit in a couple of seconds. But there isn't really a whole lot of blood. And we're looking at this, and this is exactly, again, the way I see it as a surgeon, looking down at the tear in the labrum. And what I'll do here is, again, similar to the other repair, I'll get this tissue so it's sitting in the right place. That's the tissue torn away from bone right over here. I'll insert these anchors. The anchors are now made of materials that will absorb and turn into bone in the body over a course of approximately 2 years. And I'll take this tissue and I'll use this passing device and I'll pass the stitch through and I'll repair that tissue or that labrum where it's torn from the bone back on to the bone. And here you can see an example of one of the pieces of labrum stitched on and a Boy Scout knot coming down again to tie this and recreate this chalk block or this bumper. I'm putting in a new anchor. I genuinely drill a small hole. This is about 2 millimeters or 2.5 millimeters in size, so it's really not that big. You can see a little bit of bone debris that will all get washed out as soon as I take the drill out, and you'll see the small anchor slide by you and get put into the bone, and I'll continue to repair. Shoulders can go out the front, they can go out the back. We see them go out the back in football players. MRIs can show us tears where I showed you a tear, the chalk block missing in the front. Here I can see a big tear in the back side of the shoulder. And then the last part that we see is actually in the non-dominant arm of baseball players and golfers. We call this batter or golfer shoulder. On a big swing as they miss, the posterior labrum can tear. And someone comes in to see me and says, it's not my dominant arm, I don't understand. And you get into the history, or, well, I took that big swing and cut and missed. And these are things that are often need to be. Here you can see the actual labrum torn away from the bone, and there it is, sewed back into place. And they need to be repaired at times. We have a lot of physical therapists here. We always want to think about the post-operative rehabilitation. Individuals who undergo labral tears will stay in a sling for approximately 4 weeks, and they return back to their sports at somewhere around 4 months with more severe tears or more significant contact, sometimes as far as 6 months out.